تمام، خلينا نبدأ. بسم الله الرحمن الرحيم. الأول أشكر كل الحاضرين، يعني إن شاء الله تكون بداية موفقة. هو اسم الجروب اللي احنا بادئينه هو ABCDE جروب. ده mainly for cardiologist. احنا هدفنا المنظمة ديت ان احنا نجمع الكارديولوجيست المصريين في كل حتة، سواء كان في مصر، أمريكا، أوروبا، أي مكان. وان احنا نعمل سيشن. هو بداية كده احنا السيشن بتاعتنا هتبقى كل شهرين، بس احنا الهدف بتاعنا ان احنا بعد كده نوصل لكل شهر او ممكن ايفن كل اسبوعين على حسب المشاركة اللي موجودة معانا. السيشن بتمشي ان احنا هيبقى فيه جروب من كل جامعة من جامعات مصر. يعني احنا بادئين النهارده بجامعة القاهرة. الجروب ده هيعمل برزنتيشن لحالات انترستنج موجودة، او ديبيت مثلا في حالة او كده. وهيبقى موجود معانا جروب من الباناليست. الجروب ده يعني في ناس كتيرة اتبرعوا، فيعني شاكرين جدا. هيبقى موجود معانا النهارده دكتور احمد سامي، دكتور اسامه محمود، ودكتور سالم بدر. شكرا جزيلا على تواجدكم معنا. هم كارديولوجي اتندنجز في US. هم اللي هيبقوا موجودين، الباناليست موجودين معانا. وان شاء الله الهدف ان احنا نوسع الباناليست بتوعنا، بحيث مثلا لو احنا هنتكلم النهارده على موضوع معين، هيبقى فيه بايونيرز موجودين مثلا في الموضوع ده، بحيث ان هم يشاركوا ويقولوا ارائهم. وهيبقى في كوبريشن ما بين الجروب اللي موجود في مصر او في امريكا، او حتى احنا بنعمل ريكروتمنت دلوقتي لناس موجودين كمان في اوروبا. وفي كمان كليفلاند كلينيك في ابو ظبي. فبنحاول ان احنا نجمع الناس دي كلها، بحيث ان احنا نعمل مشاركه للكيزز اللي موجوده معانا ان شاء الله. الجروب ده يعني هو نون بروفيت اورجانيزيشن. هدفنا هو ان احنا نساعد بعض، نشر المعرفه في الاول وفي الاخر يعني. ولو في حد عنده اي اقتراحات، احنا طبعا فيري اوبن ان احنا نوسع الموضوع. على اللونج ران احنا يعني بنأمل ان يكون لنا تواجد على ارض الواقع في مصر. يعني يبقى في حاجه موجوده في مصر، مش بس عباره عن زوم ميتينجز او سيشنز اونلاين. هدفنا ان احنا نعمل ورك شوبس بعد كده موجوده في مصر. زي مثلا الحاجات اللي احنا بنفكر فيها ان احنا نعمل ورك شوب للرايت هارت كات مثلا في مصر، بحيث الناس تشارك معانا ونشارك المعلومات كلها. فده الهدف بتاعنا. فان شاء الله يعني نعرف نحقق الهدف ده. وفي ناس كتير عارضه المساعده، فيعني شكرا جزيلا. آه النهارده معانا جروب القصر العيني، في معانا احمد اسامه وفي ابرام. الاثنين، ابرام ده سينيور ريزيدنت جامعه القاهره، احمد اسامه مدرس مساعد جامعه القاهره. السيشن النهارده هنتكلم مينلي عن البلمونري امبوليزم. عندنا تو انترستنج كيسز في البلمونري امبوليزم. هيبداوا النهارده ان شاء الله معانا، هيعملوا برزنتيشن. والبانelists اللي موجودين معانا شاكرين هيشاركوا معانا ويقولوا آرائهم. ولو في أي حاجة جديدة بتتعمل في الحالات اللي زي ديت، حابين إن هم يشاركوا فيها، مفيش مشكلة. وفي الآخر خالص حابين نسمع اقتراحات الناس، سواء الاتندنجز أو الناس المشاركين معانا. بحيث لو في أي حد عنده أي اقتراح نوسع الجروب ده، أو إن إحنا نعمل حاجة أكبر. فإحنا فيري أوبن إن إحنا نسمع من كل الناس. وإن شاء الله تكون بداية موفقة بإذن الله. دكتور احمد سامي، اي حاجه قبل ما نبدا؟ حابب تشارك اي حاجه؟
Hi everyone, Assalamu alaikum. I think this is a great initiative and I'm excited to see everyone here. So hopefully we get a momentum for this, and I think the success of this group gonna be by its participations. So it's دي حاجة جديدة كلنا بالنسبة لنا، و I think إن احنا عايزين بس يعني ننجح مع بعض ونتعلم من بعض and share experiences أمريكا في مصر and beyond. فيعني إن شاء الله تبقى بداية موفقة و let's kick it.
باذن الله باذن الله. دكتور سالم.
أنا عاوز أحيي كل واحد اشترك في المبادرة دي. أنا شايف اللي دي هتفيد الناس كلها، وكلنا بنستفيد من بعض. وده دورنا، اللي احنا أي حاجة اتعلمناها هنا نعلمها للناس التانية في مصر. أنا
شكرا.
متشكر جدا إن أنت اديتني الفرصة إن أنا أبقى بارتيسيبيت.
شكرا جزيلا دكتور سالم. دكتور اسامه.
ربنا يكرمكم، فرصة جميلة، الواحد مستني حاجة زي كده من زمان. فنتمنى زي ما انت قلت انها تتحول لحاجة على أرض الواقع. يعني
باذن
مش
الله.
مجرد بس يعني اونلاين ليكتشرز او سيمينارز، ولكن نتمنى ان احنا نساعد بايدينا في مصر، ندرب الناس، نساعد الناس حتى تيجي تتدرب في ديسيبلينز معينة او في فيلد معين. فان شاء الله
بالظبط.
تبقى فتحة خير يعني.
يا رب بإذن الله بإذن الله. شكرا جزيلا مرة تانية، وشكرا جزيلا للناس اللي حاضرة معانا. إن شاء الله نبدأ البرزنتيشن بتاعتنا. إبرام، أنت جاهز؟
اولا شكرا جزيلا لكل الاورجنايزيشن طبعا، ولكل الاورجنايزرز، للبانelists، الكوردينيتورز والمودريتورز وكل الناس. وبروجكت قوي جدا ان شاء الله يكمل ويبقى اقوى مره بمره. البانelists يزيد عندنا، البرزنترز كمان يزيدوا، وان شاء الله نستفيد كلنا. و this is what we're looking for, an enriching discussion ونexplore expertise في اماكن مختلفه. وإن شاء الله خير. طيب، أنا أحمد سنة، assistant lecturer زي ما دكتور شبل قال، كارديولوجي في القصر العيني. أعتقد أنا كنت محضر كده صورة للقصر العيني، قلت يمكن يكون في ناس مش عارفين القصر العيني، بس كل الموجودين بقى مصريين فخلاص. والبريزنتر التاني هيكون إبرام يونان، سينيور كارديولوجي ريزيدنت برضه في القصر العيني. وهو هيبدأ بكيس 1 إن شاء الله. وإن شاء الله تتبسطوا بالكيس ونسمع منكم ديسكشنز ثرية بإذن الله. اتفضل يا
مساء الخير. أنا برام يونان زي ما أحمد أسامة عرفني. أنا سينيور كارديولوجي ريزيدنت في كايرو يونيفرسيتي هوسبيتالز. فرصة يعني كويسة جدا إن أنا أكون معاكم النهاردة. نبدأ بأول كيس. Our case is a 60-year-old gentleman. He's a chronic heavy smoker with 30 pack years smoking history. No significant medical history, no history of substance abuse. His family history is non-contributory. He came with a complaint of acute shortness of breath. The patient presented to the emergency department with acute progressive dyspnea at rest over the last 3 days, associated with no orthopnea or PNDs, but it was associated with left-sided localized stitching chest pain that increases with inspiration. He also reported one syncopal episode on the day of presentation. 1 week prior to the presentation, he had a left knee trauma without fracture, after which he was mostly bedbound with very limited mobility. There were no fever, cough, expectorations, or hemoptysis, and the patient denied any symptoms suggestive of other systems involvement. On presentation to the emergency department, the patient was sleepy and lethargic. His blood pressure was 70 over 50 millimeter mercury. He was tachycardic, heart rate was 120 beat per minute, tachypneic with respiratory rate 40 breaths per minute, and his oxygen saturation on room air was 86%. His chest was clear. He had jugular venous distension. Also, he showed signs of hyperperfusion like cold extremities and absent pedal pulsations, and there were no clinical signs of DVT. That was his EKG on presentation. It was positive for sinus tachycardia, normal axis. We can appreciate the presence of the S1 Q3 T3 pattern. Also, we have deep T-wave inversion in precordial lead from V1 to V4, and also in lead 3 and the AVF. So, based on this clinical presentation, we have a 60-year-old man, free medical history, coming presenting with acute dyspnea, associated with pleuritic chest pain and a syncopal attack. All of this in the context of a history of trauma, left knee trauma 1 week before presentation, and the patient had a limited mobility. This was associated with the physical findings of shock, respiratory distress and hypoxemia, and jugular venous distension. With ECG, we had a very high suspicion of high-risk pulmonary embolism. And given his hemodynamic instability, we proceeded with bedside echocardiography. Here in the echocardiography, first view, we can see a parasternal long axis view. We can appreciate normal left ventricular function and dimensions. We can also appreciate dilated and enlarged RVOT. With color Doppler, there were no significant mitral or aortic regurgitations. In tricuspid inflow view, we can see what seems like a multiple large mobile thrombi filling the right atrium and traversing the tricuspid valve. With color Doppler on the tricuspid valve, we can appreciate a mild tricuspid regurgitation. In the parasternal short axis view, we can also appreciate the enlarged right ventricle, D-shaped right ventricle, and the flattened septum. And also we can see in this view, can see the thrombi moving in the right ventricle. Here's an apical four-chamber view where you can appreciate the dilated RV, the impaired RV, and also the multiple masses or thrombi in the right atrium and traversing the tricuspid valve, and this subcostal view confirming the data. Here we can see the IVC subplethoric dilated. Also, there are some thrombi in the IVC, and it shows poor collapsibility. The pressure gradient across tricuspid valve was 51 millimeter mercury, and the pulmonary artery acceleration time was less than 60 milliseconds, denoting 60-60 signs. Now, in the context of suspicion of high-risk pulmonary embolism and bedside echo showing RV dysfunction and right heart thrombi, and at the time the CT pulmonary angiography was not immediately available, so we started management of the patient as a high-risk pulmonary embolism. Started immediate management with hemodynamic and respiratory support. Started with supplemental oxygen therapy. Vasopressors were initiated with norepinephrine infusion. And in response to this, blood pressure increased to 100 over 70 millimeter mercury with improvement of perfusion status. We also immediately started initial anticoagulation with unfractionated heparin IV bolus, 80 international units per kilogram. So at this point, we have a patient with high-risk pulmonary embolism with right heart thrombi or thrombus in transit. The treatment options, according to the guidelines, we have in the pulmonary embolism 4 options. First, the anticoagulation, which will not be the only option in our patient. Also, we have other 3 options, which are systemic thrombolysis, catheter-directed therapy, and surgical embolectomy. The first option always will be thrombolysis in the absence of contraindication or high to its use or high bleeding risk. Catheter-directed therapy was not available at our institute at that time, so we started with reperfusion therapy using systemic thrombolytic therapy. There were no absolute or relative contraindication for it, so the decision was to start tissue plasminogen activator infusion with altiplase 100 milligram infusion over 2 hours, which is the regimen used in pulmonary embolism.
معلش يا ابراهيم, sorry to interrupt you. هو انت قلت انه كان في history of trauma recently, مظبوط؟
Yes.
هو كان في سيرجري ولا ما كانش في سيرجري؟
لا, هو كان عنده history of knee trauma, left knee trauma قبل ما يجي لنا باسبوع. ما كانش حتى فيه fracture او حاجه, بس هو كان حركته يعني very limited. الاسبوع اللي فات ده تقريبا كان يعني على السرير بس طول الوقت الفتره دي.
ما كانش on DVT prophylaxis ولا اي حاجه, مظبوط؟
لا خالص. Okay, the response to the thrombolytic therapy was marvelous, and the patient showed dramatic improvement. Within 1 hour, his blood pressure started to increase, reaching 130 over 80 millimeter mercury. Heart rate decreased to 90 beats per minute. So we were able to stop norepinephrine completely within 2 hours. Furthermore, his respiratory condition improved significantly. Respiratory rate decreased, and oxygen saturation rose to 95% on room air. Follow-up echocardiography immediately after thrombolytic therapy. Here we can appreciate the RV is still dilated and impaired, but we can appreciate that thrombi nearly completely had complete resolution. And the pulmonary pressure gradient across the tricuspid valve decreased to 22 millimeter mercury from 51 millimeter mercury before thrombolytic therapy. So after thrombolytic therapy, the patient was shifted to unfractionated heparin infusion for the following 48 hours, then shifted to apixaban 10 milligram twice daily for 7 days, then 5 milligram twice daily. These were his labs during hospital stay. On admission only, it was significant for leukocytosis, high serum creatinine 2 milligram per deciliter, and high CRP which was 73. And on discharge, all his labs were within the normal ranges. Also, during the hospital stay, workup for malignancy, including pelvic abdominal ultrasound, CT chest colonoscopy, as the patient didn't have any surveillance for malignancy before, and always workup was negative. And on discharge, the patient was totally asymptomatic with a very good functional capacity. And the plan was to continue on direct oral anticoagulation for 6 months and then to follow up. And this was his pre-discharge echo. This is a 4-chamber apical view, and we can appreciate totally normal RV dimensions and function, and the complete resolution of any thrombi, and total disappearance. And here is also the pulmonary artery acceleration time, which was 100 milliseconds, and normal dimension for the right ventricle. Thank you.
أبرام أنا عندي بس two questions. هل كان في troponins في اللابس ولا ما كانش فيه؟
Yes, Dr. Astropon was positive on presentation.
Okay. Okay. Yeah, just as a great case, just two comments in interval S1, Q3, T3, which a lot of people think is very common. Actually, it's not very common,
Yes.
right? But the most common EKG findings for acute PE is sinus tachy with right bundle branch block. But the interesting part of your EKG, you have both, but also you have T-wave inversion in the anterior leads. And T-wave inversion in the anterior leads with the right bundle, with the sinus tachy, more than the right bundle or the S1 QT3 indicates RV volume or pressure overload. It hints you it is an acute phenomena, it's not there. So it's interesting to see that with the acute PE. I'm not sure if you repeated the EKG after the echo, before discharge, and it will be nice to see the resolution of hemodynamic effect on the echo and the EKG. Maybe.
Actually, the EKG before discharge, the
Didn't
heart rate
change?
normalized, but the T wave remained, the T wave inversion
Remains.
remained the same as the presentation. Didn't change.
Interesting. Yeah. And then the second thing, which when the echo, I did not notice McConnell sign, a lot of acute PE, but the RV was dilated, and you're spot on the 60-60 sign. I think this is really also rare to see it. At least if you look for it, you're gonna find it. But I didn't feel McConnell sign shouting to me, but the RV was bigger, unless you have different views. So.
Okay, doctor, I didn't mention it. I forgot to mention it, but it was there. McConnell signed, as we can see, hypokinesis of the RV free wall and hyperkinesis of the apex. In this view,
yeah, it's obvious in this view. Yes, that's a good view actually.
Actually, I wanna add. This is awesome case, honestly. If I'm allowed to.
Yeah, sure. Go ahead.
Sorry, Dr. Ahmed. So actually, I want to make just a small point. This is Dr. Afifi. I'm a third-year cardiology fellow, so our attendings can correct me if I'm wrong. So I just basically want to add a point about the RVSP. So I heard in your presentation that the RVSP went down with treatment, and actually that's not a sign. I wouldn't think that this will be a sign of improvement of the RV function. Actually, just sometimes it's a sign of RV failure, because the RV is that's. So I wouldn't take basically the TR plus RA pressure as kind of a sign of basically improvement of the RV overload if the RV is going down, it's actually sometimes it is a sign of RV failure more.
That's very true. That's a good point. So we don't look at the RVSP or the estimated pulmonary artery systolic pressure as an isolated parameter. It's a whole clinical context, and we are actually doing an echocardiogram. So you can look at the RV function, and there was an initial improvement. So we cannot attribute this improvement in the pulmonary artery systolic pressure or the RVSP to a worsening in the RV function. But this is very true. You cannot take it as an absolute or an isolated parameter. That's an important point. Yeah. So I would like to ask our dear panelists, of course, you have seen multiple cases like these. How do you go through these such cases, and like take us through your minds, and what algorithms do you follow? Do you prefer certain intervention over the other? Like, for example, other institutes and literature would prefer going directly into surgery in such profiles, even with hemodynamic instability, with excellent results in the literature. So I would love to hear your experiences.
So a great presentation, Abraham. I'm glad that you mentioned it is high risk PE in your presentation. You didn't say massive PE. We used to classify PE on all days with clot burden. Right now we go low, intermediate, high risk. You mentioned something regarding the patient had syncopal episode. Did he hit his head? Did we rule out intracranial bleeding? Because sometimes with those patients with syncope, they might had small subdural hematoma, and with giving TBA, they end up with massive bleeding. And second question, did we rule out DVT study?
Okay, doctor. For the first question, the patient denied that he hit his head during the syncopal attack, and according to the examination, there were no lateralizing signs or any signs that suggestive of that there is any intracranial pathology at the time of presentation. And I know this doesn't exclude that the thrombolytic therapy will cause any problems. Sometimes the CT brain was maybe totally normal, or the patient is asymptomatic, and the thrombolytic causes intracranial hemorrhage, as there may be any minor effect from the trauma. But the patient was clinically fine, and he denied that his head was hit. So we proceeded for the thrombolytic therapy. This is the first question. So, doctor, can you say the second question again?
So DVT study?
Okay, no, we proceeded immediately for the echo, and with the findings, we gave the thrombolytic therapy. We didn't perform lower limb venous duplex extraction.
So I totally agree. If the patient is low risk of bleeding and he's good candidate for thrombolytic for high risk PE, I think the preferred strategy is to give thrombolytics, and we saw a good response in this case.
Okay, doctor.
It's a great case. I'm very proud. Yani, you guys followed the guidelines to the T. Yani. If we're gonna talk about the different aspects of management here, the diagnosis, you guys did not get a CTPE, which is the right thing to do in these cases, even if you don't see thrombus in transit. You suspect PE, you see the echocardiographic findings, you go ahead and give thrombolytics. So you guys, again, this is how it should be done, not waiting for a CTPE in these situations. Patients can be too unstable even to go to the scanner. So that's number one. Number two, I'm not aware of anybody who in my circle of people, yani, in the field who would take this patient to surgery. By the book, by the guidelines, this is a classic indication for systemic thrombolytic therapy. In some institutions, they would take this patient for mechanical thrombectomy, percutaneous mechanical thrombectomy. But again, I think that's rather the exception to the rule. That again, the indication here, the strongest indication, the strongest data is for systemic thrombolytic therapy. And the success rate in these patients is, approaches about 92%. So the failure rate is about 8%. And these are the cases that you could consider doing something percutaneous or surgical intervention. But to take somebody who is in, cardiogenic shock for surgery, it's a difficult case to make. Second, if you're going to do it, I think this patient needs to be placed on ECMO first. So he goes to the OR on ECMO. He goes out of the OR on ECMO till they recover. For example, if there's a contraindication to systemic thrombolysis. The question I want to bring up is, what if this patient does not respond to thrombolytics? He's within, of the 8% of patients, high-risk patients who do not respond to thrombolytics. And obviously, if there's a central PE, you could, extract mechanically or do echos or even do surgical embolectomy. But I actually had a recent case here in the hospital I'm practicing, and she's still in the hospital, that after thrombolysis, she improved, but she was still in shock. And I had, the person who does the mechanical thrombectomy take a look at the CAT scan, and he said it's so subsegmental and diffuse that he cannot do it mechanically. So maybe our panelists can shed some light on what can you do in these situations. I'm not aware of repeat thrombolysis in these patients. Is that something that you guys have seen done?
Probably not. I will say probably angiovac. Like try if you have a big thrombus or attached to the tricuspid valve and favorable. I seen a lot of actually CT surgeons and some intervention cardiologists team up and try to make a suction, absorb all of that. And if they, we have one case we did that, it did not succeed, and they did catheter thrombolytics, which just to minimize the side effects, and it was successful. But yeah, these are the two things that it come to my mind, but it's hard if you want to repeat thrombolytics, because for example, in STEMI, we will not repeat thrombolytics. It's a different situation, right? But yeah, that's my take.
I remember a case who was a massive high-risk pulmonary embolism, and she was in severe shock, and she had contraindication. She had recent surgery. She contraindication to thrombolysis. What we did VA ECMO. After that we did mechanical thrombectomy, and actually surprisingly the patient did very well. So sometimes those patients need to rest the heart by VA ECMO. And after that, do mechanical thrombectomy, and they do better.
I have a couple of comments on this case, and we can maybe jump to the second case if no one have any other questions. But if you go to the case itself, like if I follow algorithm, like the patient came with shock and suspecting pulmonary embolism from the history clinical, right? I think from management standpoint, I may, before even levofed or any inotropes or vasopressors, sorry, I think I can give fluid. Now, this can complicate the picture if you have a RV that's failing and dilated and you give some fluid, but you are in the acute setting, I may give fluid, waiting for the echo to be done, depending where are you, and with the emergency room. In the US, for example, we have the CT in the emergency room. So it's very easy to go back and forth, and this is maybe some institution can do that. But I think I personally will jump for echo, not just an echo POCUS. I have POCUS handy in the ED, or I have it in my pocket. I'm going to put it, and then, okay, the RV is big, the LV is fine. Guys, this is a PE. So I'm going to fast track things because time is kicking here, and then follow the algorithm. And just one thing, or follow the treatment. In the history, the only concerning thing in your history is the history of trauma. And even if the simple trauma, I think it's usually not contraindicated. But if you have a complicated trauma and we are not sure about it, that's going to complicate your decision for thrombolytics. And I think I shared with the email about different society guidelines, American College of Chest Physician, AHA, European Society of Cardiology. And really, trauma is not in the contraindication. The only traumatic contraindication is traumatic CPR or traumatic resuscitation or prolonged CPR more than 10 minutes. And this is very interesting to see that. So even if someone have a benign trauma or a remote trauma, I think we can pass that and give the thrombolytics. The third comment, you mentioned IVC clots and thrombus. And he's relatively young, right? So usually when we see IVC clots, we think about cancer, renal cell carcinoma, but the renal cell carcinoma in this patient going to be different because there's no history, right? And there's no continuation of a mass in the IVC and beyond, right? You have a different thrombi telling you there's something big and broken, and you have an embolic phenomena, and that led to the PEs. Like from imaging perspective, how I think about anyone with PE in a young age and I see an IVC clot, it is renal cell carcinoma until proven otherwise, or a cancer. But I think I like you guys did the cancer workup and was not there, so which is great.
Those are some amazing points, Dr. Sami. So I would love to get back to Dr. Osama's point. So if like a mechanical thrombectomy has failed, or maybe systemic thrombolysis has failed, what would be the next step? That's a very important question. And the scenario that I would say not uncommon, is that a systemic thrombolysis would fail, and we would explore the next options, whether mechanical thrombectomy and catheter-directed thrombolysis and maybe surgical embolectomy. But it's still mentioned in some case reports, I would say, in case series and actually systemic reviews, that repeat thrombolysis does have a role in such cases, especially in low doses. And new regimens, low doses and ultra low doses, they are still considered in patients with failed first attempt of systemic thrombolysis. And this actually opens a whole new discussion on which agent is to be repeated, and when to repeat it, and whether to continue anticoagulation while repeating the thrombolytic or not. Those are a lot of questions are to be asked in this matter, and it's a very important thing to ask. So yeah, thank you for the very enriching discussion.
So just to kind of wrap up, if I may, you guys did the appropriate follow-up. In this case, he's high risk for CTEPH down the line. So you guys did the repeat echo, repeat follow-up. Let me ask you one question. What's your plan for anticoagulation?
Yeah, go ahead, bro.
Okay, doctor. Here, the patient was on discharge. The plan was to repeat the echo after 3 months, to follow up the pulmonary arterial pressure and to also follow up the symptoms of the patient to assess for CTEPH, as you said. But the patient already on discharge, the pulmonary arterial pressure was low and he was asymptomatic. And we are waiting for him to come to reassess after the 3 months of the event.
The risk of CTEPH is actually low overall for patients, all comers with PE. The risk of CTEPH is reported as less than 3%. That's all comers. Of course, there's a CTEPH prediction scores and everything else, and he falls into that category that he's higher risk for CTEPH. But again, he didn't have it. My question was about whether you do 3 months of anticoagulation or you do extended anticoagulation, because technically he's not unprovoked, right? But would you consider this a major risk factor for pulmonary embolism in terms of trauma, no fracture, no surgery? How do you approach that?
Okay, doctor, our approach as the per EC guidelines that we classify the patients in 3 categories for recurrence of pulmonary embolism: low risk category, intermediate risk category, and high risk category. Our patient falls in the intermediate risk category, as his risk factor was the trauma. It didn't lead to fracture, and the patient was nearly bedbound or with reduced mobility for more than 3 days at home. And this per EC guidelines falls in the category of intermediate risk of recurrence. It's considered a transient, reversible, not a major risk factor.
Mm-hmm.
And this intermediate risk category, the decision may be difficult to take. Yeah, it's not easy to take the decision to continue indefinitely or for only 3 months. And our plan was to reassess the patient after 3 months if there is any complications of the anticoagulation, if anything happened, and to take the decision. But mostly, the patient will continue indefinitely on anticoagulation based on as he falls into intermediate risk category.
Now, I would add that you have the option to do a lower dose, extended anticoagulation in these folks. Since you are kind of on the fence whether to stop after 3 months or you continue, a nice maybe middle ground is to do extended, maybe low dose Eliquis 2.5 BID. That's acceptable practice in these situations. He's 60. If he's not at risk for major trauma in terms of his occupation, and he doesn't have risk factors for bleeding or prior bleeding, I would probably, anticoagulate this guy forever. I mean, he almost died few times. And just looking at his echo, it's a quite a miracle that you guys saved him. يعني بصراحة great job يعني. I would certainly not put him through it again. He probably does have something underlying, because we hit our knees all the time and we are in bed for flu for a few days. We don't get these kind of clots. So he's certainly, a high risk individual. Even if you do the hypercoagulability workup and it's completely negative, I would still consider him a high risk for recurrence, just based on the clot burden he had.
That's amazing, and that's a very good point. And I think this goes with what guidelines has to offer and recommends. And so after 3 to 6 months of standard anticoagulation of apixaban 5 milligrams twice daily, we may, if the patient is a candidate for extended anticoagulation, we may consider a prophylactic dose or the 2.5 twice daily, or 10 milligrams if it's rivaroxaban. Yeah, amazing.
I will ask one question. Do you guys see any rule for IVC filter in this patient?
Per guidelines, doctor, there's no rule for IVC filter. The IVC filter is used in 2 occasions if there is a contraindication for anticoagulation, or if there is no response to anticoagulation and there's recurrence of the venous thromboembolism while the patient is on it. So none of the none of them are present here, so the patient doesn't need the IVC filter.
I will agree, and the one thing that IVC filter can be indicated here, if you did not see impressive response to the treatment, like persistence of RV enlargement, no resolution of the clots that you saw on the tricuspid valve. I think the clinical, or you found he have a cancer or have thromboembolic connective tissue, whatever. I think the IVC filter discussion gonna come here, but honestly, in a patient like that, I will personally favor extended anticoagulation 6 months, just because, as you guys mentioned before, he died multiple times. So I will just wanna be sure. It's controversial, but he's young, and I will give him more. So, which is very interesting. So.
I agree with what mentioned about IVC filter, but I would do ultrasound, make sure there is no large thrombus in the iliac. IVC filter is more important in acute setting. Actually, in chronic setting, increase the risk of PE. So if there is large embolism, thrombus, DVT, and iliac arteries, proximal, not distal, I would consider IVC filter.
So I think it's very fair to bring up the discussion about the IVC filter, despite the absence of the very classic indications, as he mentioned, especially in the new era of easy intervention. It's a few minutes procedure, and we know that all the modern IVC filters are easily retrievable if the contraindication for anticoagulation has abolished or not here anymore. So it's a worth mentioning discussion. Yeah.
I have one last question about the choice of the vasopressor or the pressor for this patient. I see guys like you choose Levophed for this patient. I heard that the adding Merino maybe benefit these patients because it has a vasodilator effect on the pulmonary arteries. I'm not sure if this is like a practice that we do. Maybe the panelists can help me with that. Or sometimes I hear that you can use inhaled Merinon in these patients because we are trying to not to do like any intubation. I heard like 1 out of 5 of these patients will code once you intubate them. So we are trying to postpone any intubation for these patients as much as we can. So maybe if you have anything like that you practice, you can share with me.
You opened the can of worms. You know, it's I wouldn't do Melrinone in this case, just because of the hypotension. And Levophed is probably the best agent in these situations. Theoretically, if you wanna really flex, you can, you know, pick vasopressin because there are no vasopressin receptors in the lungs, so less risk of worsening pulmonary hypertension. But that's not the problem. This is obstructive shock. It's not a problem with, you know, arteriolar vasoconstriction. So it's all semantics. You know, whatever pressor you're going to use, just maintain normal blood pressure. That's more important for RV perfusion and RV function than what kind of agent you're going to use. If you're going to use something inhaled in refractory hypoxemia, I would maybe pick inhaled nitric or inhaled EPO rather than inhaled Melrinone. And again, these are in cases of refractory hypoxemia where you don't want to intubate them and you want to give them, you know, the last ditch effort to avoid invasive mechanical ventilation. I would give that a shot as we, you know, try to fix the underlying problem. Again, this is very temporizing. The treatment is still to try to get the clots out, you know, thrombolysis or mechanically.
Thank you so much, Dr. Osama. Any other questions before going to the next case?
So actually, I have one last question as a procedure from a procedure standpoint. For basically like mechanical thrombectomy or basically like NRE versus ECOS. And from my attending, and usually do a right heart cath before basically like doing the procedure itself. And if the mean BA pressure is above 40, or we have like a mixed venous that's very low, we usually kind of like, this is the high risk patient. And I was just wondering about the practice in other institutions and other like areas.
So I can take this question. So usually the mechanical thrombectomy or local thrombolysis, usually not for this patient, not for high risk, usually for intermediate risk. Intermediate risk, we reclassify them intermediate low or intermediate high. So it's based on the RV dilated and elevated cardiac biomarkers. If the patient RV dilated, elevated cardiac biomarkers, you can consider procedure, mechanical thrombectomy or echoes. So usually our practice, it's based on the location of the thrombus. If the thrombus is center, you can extract it. We'll go with aspiration, inari or mechanical thrombectomy. But if the thrombus is diffuse distal, we cannot reach it with with empilectomy. We prefer the echoes, the localized thrombolysis.
Thank you so much, Dr. Badr. We had a recent case that was actually coded on the table during a procedure, and was the first question the attending was asking, like, what was the BA systolic pressure? I was not scrubbed in the case, thank God. But that was the first case facing, and then when they asked the procedure, is like the BA systolic pressure was this, and then he said to him, yeah, should not have been done. So he was just wondering.
What was the baseline characteristic of the patient? Was it high risk, intermediate risk, low risk? How is the RV? How is the cardiac biomarkers? How is the lactic acid?
No, she was intermediate risk patient. I was involved later in the code, during the code, but I don't know all the details about the patient, but I was just wondering if there any cutoff from a procedure standpoint, like as an interventionist.
Yeah, usually we decide based on the RV dilated and elevated biomarkers. And those will force. There is no strong evidence, but usually what we do is the intermediate high risk. We usually go for mechanical or echoes.
Thank you so much. No, thank you. It makes it clear now. Thank you.
All right, any other questions?
I'll just add a small thing regarding the intermediate high-risk pulmonary embolism. I think I agree with Dr. Salim's opinion that the current guidelines recommendation still recommends just continuing parent anticoagulation for those patients and not to consider further maybe mechanical thrombectomy or systemic thrombolysis or any other intervention. But I think there's a very pretty big growing evidence on the benefit that this population of patients might be getting from intervention, maybe low dose thrombolysis or ideally catheter directed embolectomy and thrombolysis. Yeah. So should we move to the next case?
I think so. Do you guys want 5 minutes break before going to the next case? Almost 1 hour.
I think we should proceed.
Okay, go ahead.
Okay. So can you see the screen?
Yes.
Okay. So our next case is a 55 years old female patient. She's married with 2 daughters. Diagnosis is 18 years old. She's been postmenopausal for the last 5 years. She is known hypertensive for 6 years on bisoprolol, diabetic for 6 years on insulin therapy, paroxysmal atrial fibrillation with a CHA2DS2-VASc score of 2. She's on DOACs, apixaban 5 milligrams twice daily. No history of strokes. She has history of active malignancy, 2 active malignancies actually. Right breast carcinoma, treated with right conservative mastectomy 2.5 years ago, and currently on tamoxifen. Also left renal cell carcinoma, treated recently with left radical nephrectomy. No history of substance use disorders and no relevant family history. She came to the ER complaining of acute shortness of breath. History of present illness, the patient presented to the ER with acute onset dyspnea at rest for 2 days duration that is progressive and increased with exertion, associated with cough but no productions. 10 days earlier, she had radical nephrectomy done for left renal carcinoma. Patient was bed-bound in the early postoperative period, and on the 7th postoperative day, patient started complaining of right lower limb pain, swelling, and tenderness, for which she had bilateral venous duplex, which revealed a bilateral proximal DVT, for which she was started on subcutaneous enoxaparin. 2 days later, she presented with acute worsening dyspnea. She also reported palpitations that was rapid, regular, occurring at rest and increases with exertion. She denied any chest pain, syncope, fever, productions, or hemoptysis. Review of other systems was irrelevant apart from mild abdominal pain that's related to the surgical nephrectomy incident. Her assessment in the ER, so she was hemodynamically stable with a blood pressure of 110/70. Other vitals were significant for a heart rate of 100 beats per minute. She was distressed and tachypneic with a respiratory rate of 25 to 30 cycles per minute and with a saturation of 90% on room air. Lower limb examination was significant for differential right-sided edema and redness with tense and tender cuff muscles. Her abdominal examination was significant for a nephrectomy scar that appeared healthy and healing with primary intention. Her cardiac auscultation was significant and evident for accentuated pulmonary component of the second heart sound. And this was her EKG in the ER. We can see a 12-lead ECG showing sinus tachycardia, almost 100 beats per minute, with T-wave inversion in the inferior leads, lead 2, 3, and EVF, and the precordial leads, especially the right precordial leads. And she's in sinus rhythm at this ECG. So at this point, given her history and the multitude of risk factors that we just mentioned, we definitely had PE on top of our differential diagnosis list. And her revised Geneva score was 16 and her modified Wells score was 10, indicating a high pretest clinical probability for acute pulmonary embolism. We immediately gave her the initial dose of unfractionated heparin of 80 international units per kilogram, and she had an immediate CTPE that was done, revealing a bilateral central filling defects in the main pulmonary arteries and some of the lobar branches as well. And there was also evidence of RV dilatation in the CTPE and no signs suggestive of chronic thromboembolism, which is always important to look at in every patient presenting with suspected pulmonary embolism and having a CTPE. And this was her CTPE. We can appreciate the, let me use the pointer. So you can see my pointer. So those are filling defects.
Yes.
Yeah, and if we continue the video, sorry, get back again.
You have to remove the pointer if you want to continue the video, I think.
Okay, that's a good technical point. Thank you. Okay, yeah. So here we can see here a long thrombus central extending from the distal part of the main pulmonary artery into the right pulmonary artery and all the way down the lobar and even the segmental branches. And we can see evidence of RV dilation, which looks bigger than the LV. Yeah, here we can see that the RV is almost or even bigger than the LV. Next. So we confirmed our diagnosis of pulmonary embolism, and we started risk stratification for this patient, which will guide the next step in management and further management. So first, we start with the clinical risk stratification with hemodynamics, which we mentioned that she was hemodynamically stable and her PSA score was 145, a class 5, indicating 10 to 24% 30 days mortality. There was signs of RV strain that were evident in both the CTPE and later in the echocardiogram. Her cardiac troponins in the ER were elevated. The patient was diagnosed with an intermediate high risk of acute pulmonary embolism. This was her transthoracic echo or POCUS upon admission to the CCU. This is a parasternal lung axis view, transthoracic echo. We can appreciate a normally contracting or actually vigorously contracting an LV with normal LV dimensions. And if we looked at the left atrium, we can see what looks like a cord-like or serpiginous mass or thrombus that's moving and highly mobile, even approaching the mitral annulus, all the way down to the mitral annulus. Can you appreciate it? I hope everyone can see it.
Yep, it's
I
there.
think it's more clear here. It's more clear here. Again, parasternal window, lung axis view. This is the left atrium, the mitral valve, the LV, and the aorta. And looking at the left atrium, we can appreciate an echogenic cord-like or a finger-like mass that's highly mobile, approaching or approximating the mitral valve annulus. In the color Doppler and the parasternal window, there seems to be no significant aortic or mitral incompetence. And again, in the parasternal window, RV inflow or the tricuspid valve inflow, we can see by the color Doppler what looks or seems to be a mild tricuspid regurgitation. And the continuous wave, we can appreciate tricuspid pressure gradient or the pressure gradient across the tricuspid valve of 45 millimeters mercury. And again, parasternal window, but this is a short axis view, a great vessel level. This is the pulmonary artery, the main pulmonary artery. Can you see my pointer?
Yes.
So this is the main pulmonary artery and right and left main pulmonary branches. And we actually used the pulsed wave Doppler at the RVUT, which showed an acceleration, pulmonary artery acceleration time of less than 60, again for filling one of the important criterion, echocardiographic criterion for acute pulmonary embolism, which is the 60-60 sign. And worth mentioning that the poor echo study is because the patient had a BMI of 45. She was more or less obese, or morbidly obese, I would say. So that's why it was a very technically challenging study. So this is again the parasternal short axis view, the papillary muscle level, and we can appreciate flattening of the septum in both systole and diastole, indicating a pressure overload, RV pressure overload, and a dilated RV. Apical four-chamber, and this is as clear as Mulholland's sign could ever be. We can see an almost non-contracting and akinetic RV free wall with what seems to be a hyperkinetic RV apex. And if we looked at the right atrium, you remember the mass, the finger-like or the serpiginous mass that we saw in the left atrium. We can see it here in the left atrium, and it seems to be originating or coming from the interatrial septum. Again, Mulholland sign in the mass or the thrombus moving in the right atrium. Severely dilated RV. And in the subcostal window, we can see a plethoric IBC, dilated, non-collapsible, with the same finger-like mass moving in the, or mobile in the RV, in the right atrium. So based on the findings of what seems to be serpiginous masses related to the interatrial septum with components in both the right atrium and the left atrium, we suspected that we have a clot in transit that might be traversing an ASD or a PFO. So we opted for a transesophageal echocardiogram. So this is a mid-esophageal four-chamber view, and we can appreciate very clearly that there's a I say the worm-like mass. This is a snake-like mass, maybe, traversing the right atrium and approaching the RV. And also another component of it appears from one beat to the other in the left atrium as well. This is the two-chamber mid-esophageal view, and we can appreciate a small or the left atrial component of the mass. And this is the most important view, I would say. This is the bicaval, mid-esophageal bicaval view, and we can see that the mass in the right atrium here, again, finger-like or serpiginous mass going through the PFO tract. We can appreciate the body of the mass as it's trapped in the PFO tract at this point here. And this is the X-plane image, again confirming the finding. Three-chamber view, and again the left atrial component is very well apparent. And we can see in the short axis, I think this is the most obvious view. It shows all the components of the mass. We can see the right atrial component, the trapped part of the cylinder or finger-like or serpiginous mass going through the PFO tract, and also the left atrial component. This is the 3D echocardiogram, again, showing the mass going through the PFO. And this is the in-face view, the preferred view for surgeons. This is how usually they see the inside of the left atrium, and we can appreciate that the mass is very near to the mitral annulus. So upon CCU admission, patient was immediately started on unfractionated heparin infusion with a target PTT of 60 to 80. And of course, after this, we did the transthoracic echo that you just saw, and also the transesophageal echo. And another thing that we did is to stop tamoxifen, which is a very well-known precipitating factor for pulmonary embolism, after consulting oncology for sure. So at this point, to recap, we have a 55 years old postmenopausal female who is non-hypertensive diabetic with active malignancy, bilateral proximal DVTs 10 days after radical nephrectomy, presenting with pulmonary embolism with clot in transit, or an intermediate high-risk pulmonary embolism with a clot in transit. And the management options that we have or should explore at this point are surgical embolectomy, systemic thrombolysis, percutaneous mechanical thrombectomy, and catheter-directed thrombolysis. continue on parenteral anticoagulation and monitor thrombus size. And all of these are mentioned somewhere in the literature, maybe in case reports or series, or you will find them mentioned maybe in a small amount in the literature somewhere. So do you want to take over this question? Someone want to take over this question and maybe share with us what would be the best strategy for this patient? Okay, so let me continue and leave the discussion for later. So for us as the cardiology team, we opted for the surgical embolectomy, given the very large thrombus size and burden, and the presence of both left and right heart components of the mass, and also the presence of a PFO that would definitely necessitate closure after such a heroic event. So we wanted to proceed with surgical embolectomy, but we had other parties in the pulmonary embolism response team and the heart team. The other option of systemic thrombolysis for us was absolutely contraindicated, given the history of recent major surgery and many concerns about its use in such patients. So we have very few data about such cases with clot in transit passing through a PFO. When I looked at the literature, actually, there's 3 cases. One of them actually used thrombolysis with heavy concerns regarding the possibility of systemic embolization due to the fragmentation after using thrombolysis, systemic thrombolysis. We didn't go into this debate. We didn't explore this option. It was an absolute contraindication for us. So yeah, the option number 3 was percutaneous mechanical thrombectomy and catheter-directed thrombolysis, an option that's heavily opted for and praised when it comes to right heart thrombus. And in some literature and some data, they actually went for percutaneous mechanical thrombectomy in patients who are hemodynamically stable or even unstable patients as the first option, completely ignoring the systemic thrombolysis, which is the obvious choice when it comes to the guidelines in patients with high-risk pulmonary embolism. But with that being said, our patient is a very specific category of patients, not only that they have or that he have a clot in transit, but also this mass or clot is passing through the PFO, which makes intervention with catheters very risky. You will not be able to approach the left atrial part, and manipulating the right atrial part would definitely increase the chances of the mass detaching and causing systemic embolization or stroke. So this option was also knocked off by our team. The last option is to continue in parenteral anticoagulation and monitor the thrombus size. As weird as it might look and seem, this option, if you looked at the data and the literature, you will find a couple of case reports that states that they had used parenteral anticoagulation in very similar patients with excellent results. And actually, we have some data, small caliber, but still retrospective as well, but still some data that says that parenteral anticoagulation would not be inferior in patients with right heart thrombi to the systemic thrombolysis or catheter-directed thrombolysis. So the heart team opted for continuing parenteral anticoagulation with unfractionated heparin and follow up the thrombus size in 1 week, which we did against our will, but at the end of the day, it's a heart team discussion. So we did so, and the follow-up TE showed no reduction in the thrombus size, and surgical embolectomy was done after 1 week. This is the follow-up TE after 1 week of continuing parenteral anticoagulation before the surgery, and we can appreciate that the thrombus, both the left and right atrial components, are still there, still highly mobile, very high risk, and also in the short axis 3D transesophageal echo. Again, we can see all the components of the thrombus, very scary. A quick look at the labs across the hospital course, we can appreciate that it was only significant for an elevated CRP, transiently elevated CRP, which we attributed to UTI that was treated with ciprofloxacin and quickly resolved, and a creatinine of 1.8 on admission that was attributed to her very recent radical nephrectomy and also improved along the hospital course. Those are some other labs. What's really important is the cardiac troponin, the high sensitive cardiac troponin, which was elevated on her presentation in the ER. This is the post-operative TEE, and we can appreciate that there's absolute or complete resolution or absence of any residual masses, whether in the right or left heart chambers. And if we look at the intra-atrial septum, it's unusually thicker than what we're used to, and this is because they have closed it with a dacron patch. That's why it's a little bit thicker and more echogenic. And we can appreciate a completely normal right ventricular function, completely normal right ventricular dimensions with no evidence of RV strain. This is the two-chamber view, mid-esophageal, and this is the bicable view and the 3D echo. The study is completely normal. So her post-operative course was uneventful, and the patient was discharged on the post-operative day 10. She was discharged on abexapan 5 milligrams twice daily, bisoprolol 5 milligrams once daily, ferrous gluconate and vitamin C, insulin therapy, and anastrozole, which was the second choice after we stopped the tamoxifen as per oncology recommendations. We had her come follow up with us along the past 2 years, and she's been doing very well with excellent functional capacity and being able to perform her daily activities. She actually lost a lot of weight, and her current BMI is 23. Her examination has always been within normal, and her follow-up transthoracic echo is completely normal as well. I would love to give you a very quick literature review on thrombus in transit. So what is the thrombus in transit, or the clot in transit, or the right heart thrombus? You will find multiple names, multiple nomenclatures. They usually indicate the same thing with very little variations. The right heart thrombus usually refers to a bigger entity that not only include the thrombus in transit, but also other types of thrombi, maybe in situ thrombi, or maybe other masses in the right heart. So definition, it's a blood clot that forms and migrates within the vasculature in the heart, potentially leading to severe complications, including pulmonary embolism and stroke. The clinical relevance, which is very important to know, about 4% of patients, it's definitely the incidence is variable across the data available, but the consensus is towards a 4%. 4% of patients suffering from pulmonary embolism have a floating embolus present in the right heart, a finding that is associated with a mortality rate of more than 40% with the best treatment options. If left untreated, the mortality approaches 100%. And the current management strategies, which are all reported in the literature, used as the first line, which is very weird. I think the intuition-based thinking won't take us to anticoagulation whatsoever, but still, some case reports indicates that they use anticoagulation with excellent results. So advantages of anticoagulation therapy would be the ease and rapidity of administration, and disadvantages would be pulmonary or systemic ischemic events that may occur as a result of thrombus fragmentation. So this option, usually in real life practice, we reserve this option for small, less mobile clot in transit and in patients with contraindication for surgery. And we have data from Barrios et al. That concluded that in patients with pulmonary embolism and clot in transit, there was no significant difference between reperfusion therapy by systemic thrombolysis and anticoagulation in terms of mortality and bleeding. But on the other hand, recent data that was from a research article published in the Circulation in 2024 that found that catheter-based thrombolysis and therapy or systemic thrombolysis was associated with significantly lower rates of adverse clinical outcomes, including a lower rate of death compared with anticoagulation alone, driven mainly by CPT group. Regarding percutaneous mechanical thrombectomy and catheter-directed thrombolysis, the advantages would be across all available data. It always showed a very high success rate and lower incidence of bleeding, risk of thrombus dislodgement, especially when there's a left heart component to it, or an RV or RVOT component to it. Risk of thrombus dislodgement, bulky thrombi are usually resistant to thrombolysis as well. Systemic thrombolytic therapy advantages are the ability to dissolve clots in separate places simultaneously, including the pulmonary emboli, intracardiac thrombi, and venous thrombosis, which our patient had all of them. Universally applicable intervention that can be performed at the bedside. Disadvantages would be the risk of embolization due to thrombus fragmentation and risk of severe bleeding, a very well-known side effect or a potential outcome of using systemic thrombolysis. it should be something that we should be afraid of, especially when we have a left heart component of the thrombus and not specifically knowing the age of the thrombus. As we know that using thrombolytic therapy in patients with pulmonary embolism is not like the MI, it's a little bit more, or actually a lot more, having a lot more window to give thrombolytics in patients with pulmonary embolism. We can give it up to 2 weeks after the index pulmonary embolism or the onset of pulmonary embolism. With that being said, if you give it a little bit more late or towards the end of the window, the risk of fragmentation and not being able to completely dissolve the thrombus is much higher. And finally, the surgical embolectomy, the advantages is if there's a right to left heart communication present, as in our case, surgical embolectomy allows removal of all thrombi in both right and left heart chambers, as well as providing a chance to close the communication in the same setting, which was what we did. Disadvantages: prolonged time to treatment, general anesthesia, cardiac bypass, secondary infection, and failure to eradicate concurrent pulmonary emboli outside the central pulmonary arteries. In a case report by Medina et al., emergent surgical pulmonary embolectomy was performed for clot in transit with acute massive pulmonary embolism. This is what we just mentioned. It's not what we usually do. We usually think the way we think in cases with massive or high-risk pulmonary embolism. The new nomenclature, we go for systemic thrombolysis. Seems to be a very easy decision with a very large consensus. This is what guidelines say. This is what everyone does. But still, there's some data shows that choosing surgical pulmonary embolectomy from the start was a successful technique with low risk. And this is a comparative efficacy study of different modalities of treatment of right heart thrombus in transit, a pooled analysis. Though they analyzed data for 328 patients with pulmonary embolism and right heart thrombus or thrombus in transit, patients from 1992 to 2013, and they found that mechanical thrombectomy and systemic thrombolysis, as well as surgical embolectomy, were much superior to no treatment at all or treatment with only anticoagulation. With that being said, I do myself personally, and this is what most of the data and literature says, there's no consensus when it comes to the management of thrombus in transit or pulmonary embolism with thrombus in transit, and it should always be individualized. And with that being said, there's a lot of centers, a lot of literature or data that proposes different algorithms for making it easier for physicians to be able to manage patients with clot in transit. And this is one of the proposed algorithms for management of clot in transit, according to the Patel et al., published in the Curious 2022. I think what's more important than strictly following the algorithm is knowing what they thought about putting this algorithm and how they approached the patient. So they looked at the hemodynamic state, they looked at the risk of the patient, they looked at the available facilities and the expertise in the place and the resources available, and also the presence of right to left heart communication. This is another algorithm which I personally prefer. This is the current pathway for right heart thrombi management with concomitant pulmonary embolism, proposed by Yale New Haven Hospital. And it's more or less similar to the previous algorithm, but we can see here that they added a special entity, or they specifically mentioned a PFO or right heart thrombus trapped in a PFO, which gives us an idea that this is there's increasing data or increasing case reports with such profile. So yeah. Finally, the take-home messages. We believe that TE is generally a safe procedure for diagnosis of clot in transit, and actually a very accurate intervention. In some reports, they report that it might be even more accurate than the CTPA, but pressure changes associated with Valsalva maneuver may induce embolization for clot in transit, so care should be taken. Treatment for clot in transit is controversial due to the lack of prospective randomized clinical trials, but a cardiothoracic surgeon should always be consulted after the diagnosis. Management of clot in transit should be individualized with many factors taken into considerations: hemodynamic stability and hemodynamic state, the risk of the patient, thrombus size and location, presence of right to left heart communication, and components to the thrombus itself. And thank you so much.
Great presentations. So I have few questions. So I think I agree with what you have done. The team discussion with the surgery is the key. Those cases are not clear. And I think the surgical embolectomy is a treatment of choice for those patients if they are good surgical candidate. But what I would do differently, I would consider IVC filter, especially with proximal significant clot burden in the proximal lower extremity veins. And also on discharge, you discharge the patient on apixaban, but she was already on apixaban before. So do you think it will change the long-term outcome?
That's a very good question. So I think the discussion about the IVC filter is very valid, given that she might have been on anticoagulation, especially after she was diagnosed with proximal DVT. She received parenteral anticoagulation, which we're not very sure. We're not very sure that she's been taking when she was discharged home. We're not very sure. The patient herself cannot exactly remember. But yeah, it's a valid point. It should be taken into consideration. And yeah, and being discharged on apixaban, I think apixaban in terms of preventing stroke, that was the first indication. She was on apixaban for AFib, and it was very successful. She never had a stroke. That's a new indication, a different indication, and I think there is room for using apixaban in such patients, despite many other expertise would opt for low molecular weight heparin, I think.
So you think she wasn't compliant in first place? That's why she had.
We're almost sure that she was not compliant to enoxaparin subcutaneous when she had the proximal DVTs, but when it comes to apixaban as part of stroke prevention, as part of AFib treatment, yeah, she was compliant at that time, and it was successful.
I totally agree. So I think the treatment of choice is surgical embolectomy if the patient is good surgical candidate. I think systemic thrombolysis, no rule here because the risk of fragmentation of the thrombi, as you mentioned, and stroke. I think if she is not a surgical candidate, we can consider doing catheter base, mainly angiovac, aspiration of this. But again, we have to do protection of the carotid. We can use central, just protection of the carotid from stroke, central devices. But I agree with you, the surgical embolectomy is the treatment of choice.
I have one question, if you don't mind. Like, if you can go to the TE on the fourth chamber mid-esophageal view, just I will pick your brain about something. Just a question, if you don't mind.
Yeah, sure. Yeah, go ahead. Sure.
Yeah, can you show the image?
Yeah. Just
Yeah. And just while you're bringing it, I will share a nice review article from ACC about anticoagulation for cancer patient. And they talk a little bit about a lot of strategies. And I know you guys may follow the AAC, but the one I sometimes follow in these algorithm is the
is this the
how
view you wanted?
yes, there is a nice risk calculator. They usually call it the Corona score, and a lot of oncologists actually use it to decide that more than cardiologists. But I think using it multiple times is make things easier. I will tell you, like a patient like that here, they're going to be lifelong low molecular weight heparin, no question. But some people can have different algorithm, depends on things. Okay, so my question to you here, look at the mitral valve and the tricuspid valve, and do you think there is a gap? I'm hinting this patient is young, and if this is a case of Epstein or Epstein. Is the tricuspid, the mitral tricuspid gap, is it big enough? Like I'm trying to say, do we have any atrialization of the tricuspid valve? I think it reached 1 centimeter if I measure it. I'm not sure.
That's yeah. Go ahead.
The only caveat here, depending on how you are obtaining the view. You are at 19 degree, not at 0. So you probably have some flexion, and it can be over shortened by the TE view. Just, when I think a little bit about a young patient with a PFO and that view, I would just put it in my mind. Yeah.
That's a good catch. And I do agree, but I think that the apical views in the transthoracic was not really evident for such a thing. But yeah, it's a very good point.
Yeah, but I mean, this excellent presentation. You guys slamming PE in Egypt. You are guys doing great. By the way, all these
Thank you so
cases,
much.
you can like literally. I think there's just a feedback. If you guys have, I know, like, لو عايزين تكتبوها مثلا case report أو تكتبوها مثلا challenging cases.
Yeah,
Any of
already. Yeah, we did so. Yeah,
Yeah,
we
any
did.
of these cases can go for, because you have such excellent cases and multi-imaging and cath. It can go to JACE for case for American Society of Echo. It can do for JAC case report. It can go for Annals of Internal Medicine case report. It can do for the AEC case report. Tons of opportunity لو انتوا عايزين تكتبوها يعني, which I think may help. But
Thank you so much, Dr. Ahmed. We would definitely appreciate your help and expertise in such thing. Yeah, we definitely we're planning to. I think Bram did this to his case, and he already. I think he's in the process of publishing it as a case report, and I'm actually planning to do this as well. And I would definitely appreciate your help with this.
yeah, and the other
Yeah,
venue. The
yeah,
other venue, the ACC Middle East, this year. I'm not sure if you guys go or not. It's gonna be in Dubai, so which is close. Yeah, I mean, just an idea. Just don't worry about it. That's just an idea.
amazing one. Thank you. So, and yeah, speaking of the Corona score that you mentioned, it's a very important thing, and I think we're starting to understand it more and use it more as cardiologists, as per the very recent cardio-oncology guidelines by the ESC. They do mention it a lot. But just to make it clear, we use it for predicting the risk of PE or VTE in patients with malignancy, depending on the type of malignancy, platelets, TLC, and different multiple variables, which stratifies the patient with high risk of VTE, intermediate, or low. And based on this, we give prophylactic anticoagulation and not therapeutic. In this case, I think no place for the use of Corona score. This patient already had massive pulmonary or high risk pulmonary embolism. So yeah, that's a very good point. Thank you so much.
A great case and great management, mashallah. Yani. Did the just some stimulating questions. Did the PISI score help you here?
I think in the first, that's a very good question with a lot of things to say. I would
And
say,
I'm not asking you, I know you know, but I'm asking because of the sake of the junior, colleagues on the call.
yeah.
Go ahead.
So yeah, so I think that this is the way it should go when you're risk stratifying patients with pulmonary embolism. We don't immediately start with troponin or imaging. We do simultaneous clinical and imaging assessment, and actually clinical assessment precedes imaging assessment. So we don't jump to the signs of RV strain. We definitely should do it as it's indicated for confirming the diagnosis, and actually risk stratification comes after fulfilling the diagnosis. So we cannot risk stratify patients who are not yet or just only suspected to have pulmonary embolism. So clinical risk stratification with number 1, hemodynamics, and number 2, PCA score or simplified PCA score, and multiple other scores that are not, I would say, inferior according to the wording of the ESC, like the BOVA score and other scores, but the PCA score still stands out as the most predictive of them. So yeah, it should be before imaging and troponin as well.
The point of caution I'm trying to bring up is, if your PISI score is low in this situation, would you have treated the patient different, right?
So that's a good thing, but you can see that it's a retrospective thing. It's a retrospective question. So when we used the PESI score as the patient was admitted to the CCU, we didn't know that he has a clot in transit. So we followed the algorithm. That's what we had to do according to the algorithms of the guidelines. But when we discovered the clot in transit, and maybe you have noticed this, when I recap the case, I mentioned that we have a case of pulmonary embolism with clot in transit. I completely ignored the pre-classification according to the risk stratification of this patient being an intermediate high risk because the
You're
presence
talking
of clot
about
in
the
transit.
Geneva. You're here talking
Yeah,
about the Geneva. Yes. No, I'm talking about
I'm talking.
the PISI score is a, as
Yeah.
you mentioned, is a risk stratification score. But the main strength of the PISI score is actually in low risk patients where you are trying to decide whether to send them home immediately after diagnosis with oral anticoagulation, or you want to admit them to the hospital. I agree with you 100%. It needs to be done. You guys did it textbook, no question about it. But the point of caution, even in the guidelines, that even if the PISI score is normal or low, you still rely heavily on the two other variables, which is, the echocardiographic evidence of RV dysfunction, and the second is cardiac enzyme levels. So even if the PISI score was low in this situation, and it can be sometimes falsely low if it's a younger, healthier patient, you still would stratify this patient as an intermediate high risk, and you would treat them like you absolutely very excellent did in this case. I'm just trying to bring the attention of the residents on the call not to get hung up on the PISI score. It's important, you need to do it, but it doesn't rule out a high risk situation if the other variables, the stronger variables in this case in terms of prognostication, tell you otherwise. So that's one. Second is, the intervention piece. That's a huge topic. I don't think we'll have time to talk about what to do in intermediate high risk patients in terms of, thrombolysis versus mechanical, removal options. But this is one of the scenarios where technology is moving much faster than evidence. There's nothing that compares in a randomized, strong fashion, mechanical thrombectomy or catheter-based interventions versus thrombolysis. All of it has been catheter based against each other or catheter based against anticoagulation only. So it's a data free zone. Probably there's a benefit to catheter based compared to anticoagulation or systemic thrombolysis just because of the risk of intracranial bleeding and major bleeding in patients with systemic thrombolysis. Registry analysis and retrospective studies confirming that. But again, it's still, the evidence it didn't make it to the guidelines yet. I think it will probably in the next iteration of the guidelines. But I agree with Dr. Bedr about the IVC filter. This is a patient with cancer that had a recurrence or had an event on anticoagulation. And I also agree with Dr. Sami about the choice of anticoagulation. If you look at the ASC guidelines, actually, apixaban is not recommended as an alternative to low molecular weight heparin. So they give you the choice to pick low molecular weight or edoxaban or Xarelto. They actually don't give you the choice to pick Eliquis in these situations. So that's the only thing I would do different. I would certainly put an IVC filter in this lady who almost died, and I would maybe pick something else that's more in line with the guidelines.
That's great. That's great. Very nice. Yeah. Any other comments, questions?
Unless you guys have questions, specific questions for us, we're happy to answer them.
If I can just add a very small follow-up to what Dr. Osama thankfully said, the importance of evaluating the other prognostic markers, not just the PISI score, that Dr. Osama said. And even if you have a low PISI score, class 1 or 2, even if you have a normal or not elevated troponin, even if you have no signs of RV strain, there's still other scores that you have to make sure that is negative, that does not predict or necessitates the admission of the patient to the hospital. For example, the Hestia score, which gathers some other criteria that you have to make sure that it's all negative before discharging the patient home. But yeah, it's a very good point. So any questions?
Just curious, did you guys take this patient on ECMO to the operating room, or she didn't need it?
No, she was hemodynamically stable all the way, and she
Okay.
didn't need it. Her blood pressure before surgery actually was 120/90, so yeah,
Okay.
she did very well. And yeah, getting to the point of choosing the agent of anticoagulation, she actually went on apixaban and she continued on apixaban. I think there's growing data on the use of apixaban in patients with malignancy, despite what the guidelines say. I do agree with you on that. But she didn't have any recurrence of her pulmonary embolism or DVT or any other events, and she's doing very fine. I know that we cannot take a single case as proof for something or as an evidence, but still, what's your opinion about that, Dr. Sam?
Are you asking if about the Eliquis?
Yeah, would you ever consider it or?
Yeah, so here in the West we care about liability a little bit more than how we practiced in Egypt. So in the court of law, you're going to be asked, what does the guideline say? And you cannot defend yourself to say, okay, the guidelines say this, I did something else because I think, the guidelines are not updated or it's not correct. So that's one aspect of it. The second aspect is you have to take, the strength of something that made its way to the guidelines and take it seriously. I mean, these are a huge number of people with world-class expertise in the fields they are writing the guidelines for. So you should really trust in it, especially if it's from the ACC or ASC. In this situation, I would for multiple reasons I would pick something that is recommended in the guidelines rather than something else. Especially that you have the options in this case. You're not limited. Um, so that would be my personal practice in this situation.
Amazing. Thank you. Thank you so much.
Yeah, absolutely. Great cases, guys.
شكرا جزيلا أسامة وإبرام، يعني ما شاء الله cases very interesting، ومجهود رائع في البرزنتيشن وتحضير الحالات، يعني بصراحة يعني فوق المتوقع. شكرا جزيلا جدا. هل حد عنده أي اقتراحات فيما يخص السيشنز اللي جاية أو فيما يخص ABCDE Cardiology؟ We are very open to hear from you guys.
عايزين جراح المرة الجاية.
حاضر. المرة دي عدت مني، معلش.
يعني depends بقى على موضوع المرة الجاية إن شاء الله. احنا هنحاول نخليها ان في الاول كان الموضوع presenting a case regardless التوبيك يعني او الكونديشن او الدايجنوسيس، فطرحت على دكتور شيب ان احنا نخليها زي days، يعني pulmonary embolism day او session، heart failure session، فتبقى حاجة واحدة بحيث ان يبقى وبتاكل برضو مواضيع مهمة. طبعا الدسكشن فيها اكتر من كده بكتير ولكن الوقت لا يسع في multiple aspects. فلو هي يونيفايد في موضوع واحد اعتقد الاستفاده هتبقى اكبر بكتير، لانه الكلام هيبيلد اب على الكيس اللي قبله، وطول ما احنا ماشيين يبقى في ديسكشنز واراء مختلفه. فصراحه ديسكشنز ثريه جدا. للاسف اسوأ حاجه فيه ان هي هتخلص، عايزين نسمع اكتر بصراحه. بجد الدكتور اسامه ودكتور سامي ودكتور بدر وكل الموجودين، شكرا جزيلا يعني.
لا، انتوا طمنتونا على اهلنا في مصر. ما شاء الله عليكم، يعني ربنا
جزيلا
يزيدكم
شكرا.
يعني يعني وورد كلاس بصراحة، وورد كلاس يعني
Thank you so much.
يعني go for it.
Thank you so much.
والجراحين هيبقى ليهم رأي في كل حاجة ما عدا الاي كي جيز، يعني طالما ما اديتوش اي بي كيس هيبقى ليه رأي، ما فيش مشكلة خالص يعني.
آه بس يعني one comment I think ان احنا يعني بعد كده يعني ان شاء الله هنعمل دي frequent، يعني يعني ممكن decide about it، يعني نعملها ساعة نعملها ساعتين، يعني we can shorten the presentation increase the discussion، يعني كل الحاجات دي up to us right، يعني US team Egypt team whatever team احنا يعني the learning is phenomenal، and I think I learned myself a lot of things today better than any conference. يعني ما شاء الله يعني I think I like the idea ان احنا لو عملنا cases يبقى في مثلا الobjective زي ما انتوا بعتوها في الجوجل document. I really like that a lot، ان ده بيخلينا prepare، وبعد كده presentation اللي تعملوها بعد الكيس ان انت let's wrap it up learning curve. I think دي برضو هت enhance ان احنا نشare and learn from each other.